Ectropion. Ectropion comes from the Greek word ek, which means out, and trepion, which means to turn. It is a condition in which eyelid is turned away from the eyeball. Anatomy. The eyelids are two fibromuscular structures, outer layer containing skin, muscle as well as dense fibrous tissue, and an inner transparent layer called conjunctiva, that close in front of the eyeball, hence protecting it. Any pathology in these structures can cause failure of the eyelid to retain its normal position, resulting in ectropion or eyelid being turned away from eyeball. Causes. Ectropion can be caused by muscle weakness. As you age, the muscles under your eyes tend to weaken and tendons stretch out. These muscles and tendons hold your eyelid taut against your eye. When they weaken, your eyelid can begin to droop. Facial paralysis. Certain conditions, such as Bell's palsy and certain types of tumor, can paralyze facial nerves and muscles. Facial paralysis that affects eyelid muscles can lead to ectropion. Scars or previous surgeries. Skin that has been damaged by burns or trauma can affect the way your eyelid rests against your eye. Previous eyelid surgery can cause ectropion, particularly if a considerable amount of skin was removed from the eyelid at the time of surgery. Eyelid growths. Benign or cancerous growths on your eyelid can cause the lid to turn outward. Genetic disorders. Rarely, ectropion is present at birth, congenital. When it is, it's usually associated with genetic disorders such as Down syndrome. Signs and symptoms include: if you have ectropion, your lower lid pulls away from your eye and tears don't drain properly into the puncta. The resulting signs and symptoms can include watery eyes, excessive tearing. Without proper drainage, your tears may pull and constantly flow over your eyelids. Excessive dryness. Ectropion can cause your eyes to feel dry, gritty and sandy. Irritation. Stagnant tears or dryness can irritate your eyes, causing a burning sensation and redness in your eyelids and the whites of your eyes. Sensitivity to light. Stagnant tears or dry eyes can irritate the surface of the cornea, making you sensitive to light. Treatment. Definitive management is surgical. Medical management is temporary, but can improve symptoms while awaiting surgery. What is sty? Before we answer this question, we need to know about anatomy. Both of our eyes have eyelashes arranged in 2 to 3 rows anteriorly along the eyelid margins. Each eyelash follicle is associated with oil-secreting glands called glands of Zeiss. Another oil-secreting glands called meibomian glands are also present in the dense connective tissue plates, also known as tarsal plates, which also provide skeletal support and are placed posteriorly in the eyelid. External hordeolum or sty. Hordeolum, that is Latin for barley, a type of cereal grain, is a medical term used for a swelling in the eyelid resembling a grain of barley. Sty, or external hordeolum, is an acute infection, usually from staphylococcal bacteria, of the lash follicle and the associated glands of Zeiss. Same infection occurring in meibomian glands is called internal hordeolum. Signs and symptoms. Patient will present with a tender swelling in the lid margin, swelling pointing anteriorly through the skin with a lash at its apex. Redness and edema may also be present. It can also appear as multiple lesions, as infection can spread from one lash follicle to the next. It can also lead to preseptal cellulitis. Treatment. It may occasionally resolve by itself. The eyelash should be plucked to promote drainage if the pus point is present. Hot compresses should be done to localize the infection, pus point, and also for patient comfort. Oral antibiotics may be given, especially in diabetic patients and recurrent cases, as oral antibiotics reach the internal eyelid structures more easily than eye drops. Topical antibiotic ointment should be applied to prevent adjacent infection. Treat associated blepharitis if present. Incision and drainage may be required in severe cases.
What is chalazion? Before we answer that question, we should talk a little bit about anatomy. Structural support to our eyelids is provided by dense plates of connective tissues called tarsal plates. Each tarsal plate has vertically placed oil-producing sebaceous glands, called meibomium glands, in them. 25 in the upper and 20 in the lower tarsal plate. Meibomium glands secrete meibum, an oily substance that prevents evaporation of the eye's tear film. If these meibomium gland orifices at the lid margin become plugged or blocked, the contents of the glands, meibum, start getting released into the tarsal plate and surrounding eyelid soft tissue, causing an inflammatory reaction. It is also called lipogranuloma because the retained lipid secretions are causing aggregation of certain cells, causing this granulomatous inflammation. And it is sterile inflammation as there are no microorganisms causing infection. Signs and symptoms. It can be either chronic, in which the patient will present with gradually enlarging, painless swelling of the eyelids, or acute, in which a sudden painful swelling of the eyelid will be there. On examination, a visible or palpable, well-defined subcutaneous nodule in the eyelids will be present that may or may not be tender. Bulging, thickened secretions may be present at the orifice of the involved gland. Treatment is mostly conservative as 1/3 of the lesions resolve spontaneously, so simple observation is enough, especially if the lesion is showing signs of improvement. Hot compresses with massage 4 to 5 times daily also helps in its resolution. Oral antibiotics are required for significant bacterial infection, but not for sterile inflammation. Steroid injection is also used especially in the lesions near lid margin or the lacrimal system. Surgery. For persistent lesions that are not resolving spontaneously, surgery is done.
Ptosis. Ptosis comes from the Greek word that means to fall. It is an abnormally low position or drooping of the upper eyelid. First, let's talk about anatomy. We are able to lift our upper eyelid up with the help of 2 muscles. The main one that does all the work is called levator palpebrae superioris, which attaches to the lid structures, including the lid skin causing upper lid crease through an aponeurosis, and the minor one is called Muller muscle. Both of them work when they get signals from the brain through different nerves. Any disease affecting them would lead to ptosis or drooping of upper eyelid. Causes. These include acquired, congenital. Acquired include 1. Neurogenic. Basically, there is an innervation defect of the muscles, and because nerves supplying the muscles are not working, the muscles will be unable to work properly. 2. Myogenic. A. Impairment of transmission of impulses from the nerve to the muscle at their junction, e.g. myasthenia gravis. B. Myopathies, which means pathology of the muscle itself is directly affecting the muscles involved in eyelid lifting. 3. Aponeurotic, also known as senile ptosis, in which there is age-related atrophy of the levator muscle aponeurosis. 4. Mechanical, gravitational effect of a mass pulling the lid down, for example due to a tumor. Grades. Ptosis could be mild, up to 2 mm drooping of eyelid, moderate, up to 3 mm drooping of eyelid, or severe, 4 mm or more drooping of eyelid, depending upon the amount of ptosis present. Signs and symptoms. The most obvious sign of ptosis is a drooping eyelid. Another sign is when the upper eyelid creases do not line up evenly with each other. A child with ptosis may tip their head back, lift up their chin, or raise their eyebrows to try to see better. Over time, these movements can cause head and neck problems. Treatment. Treatment consists of A. Surgery in most cases. Conjunctival and Muller resection in mild ptosis achieves 2 to 3 mm elevation of eyelid. Levator resection in moderate to severe ptosis, usually done in congenital ptosis, achieves 5 mm elevation of eyelid. Brow suspension in very severe ptosis. B. Treat the underlying cause. For example, in ptosis due to myasthenia gravis or a mechanical cause, treat myasthenia gravis or remove the mechanical cause. Myopia. Origin of the word. It comes from the Greek word myops, meaning short-sighted. These people cannot see distant objects clearly. Anatomy. Before we describe myopia, let's compare the eyeball to a camera for better understanding. When we take a picture, light after reflecting from an object enters the camera and passes through following. Firstly, it passes a transparent glass in front of the aperture of the camera. Then secondly, it passes a camera lens that helps us in focusing light rays. And lastly, there is a camera film on which light is focused for a clear picture. Eye is somewhat similar as when we see an object. Light after reflection from that object enters our eye through. Firstly, it passes cornea, the transparent curved front part of the eye. Then secondly, it passes through the crystalline lens that helps us in focusing light rays. And lastly, there is the retina. Light-sensitive receptor cells in the posterior part of the eyeball on which light is focused for a clear image. Definition of myopia. It is a form of refractive error, inability to refract, bend, focus the light rays properly, in which parallel rays of light, i.e. coming from a distinct object, after entering the eye, are focused in front of the retina instead of on retina with eye muscles at rest. Causes. Curvature. Increase of curvature of cornea or lens causes light rays to be focused in front of retina and hence myopia occurs. Axial. Increase in axial length of eye increases the converging power and cause light rays to be focused in front of retina. Index. Increase in refractive index, i.e. light bending, focusing power of the lens, for example in cataract. Positional. Anterior displacement of lens, e.g. after trauma. This again causes light rays to be focused in front of retina. Types. Congenital, from birth. Simple, most common, starts from 5 to 10 years till 15 to 20 years and is mostly due to curvature or length problem of eyeball. Pathological, hereditary, progressive, and is due to degenerative changes in the eyes. Clinical features. Symptoms. Blurred vision, half-shutting of eyes, parents of child will tell. Outward deviation of eye, divergent squint. Normal patients require to move their eyes inward while focusing near objects. This is not required in myopic patients, causing their eye to move out intermittently or constantly. Signs. Prominent eyeball, as eye is big. Retinal changes, in pathological myopia. Diagnosis. Retinoscopy, a handheld device that throws light in the eye and allowing us to observe its movements and reflection, hence helping to confirm the refractive error. A-scan, a small ultrasound probe that throws ultrasound waves in the eyeball and then detects their reflections or echo timings, calculating the eyeball length. Treatment. Unlike the camera, maximum 2/3 focusing in an eye is done by the transparent front part, cornea, while the rest, 1/3, is done by the lens. So, while treating these patients, we have to decrease the focusing power of the eye so that the image is formed on the retina instead of in front of it. This can be done by using either a diverging lens like glasses, contact lenses, or some surgical procedure. Surgical treatment. Flattening the central part of cornea. This includes different methods that were changed and advanced, depending upon reduction of side effects and recovery time and improvement of degree of vision. The surgeries included in this category are radial keratotomy, photorefractive keratectomy, LASIK, laser epithelial keratomylosis, LASIK, laser in situ keratomylosis. Other surgical treatment options are lens extraction, contact lens implantation.
Hyperopia. Anatomy. Before we can describe hyperopia, let's compare the eyeball to a camera for better understanding. When we take a picture, light after reflecting from an object enters the camera and passes through. First, a transparent glass in front of the aperture of the camera, then secondly, a lens that helps us in focusing light rays, and lastly, a film on which the light is focused for a clear picture. Eye is somewhat similar, as when we see an object, the light after reflection from that object enters our eye through, firstly, cornea, the transparent curved part of the eye, Then, secondly, through the crystalline lens that helps us in focusing the light rays. And lastly, the retina, light-sensitive receptor cells in the posterior part of the eyeball, on which light is focused for a clear image. Definition of hyperopia. It is a form of refractive error, inability to refract, bend, focus the light rays properly, in which parallel rays of light, i.e. coming from the distinct object, after entering the eye, are focused behind the retina with accommodation, eye muscles at rest. Key features. This refractive error has 3 key features. Image is formed behind the retina. In normal people, image has to be focused on the retina for it to be clear. Parallel light rays, the rays that only come from objects at 6 meters or beyond, must be used for assessment, as when objects come closer than 6 meters, light rays start to diverge, changing their focus. This is why we place Snellen's chart at 6 meters. Eye must be at rest. Just like a DSLR camera's focusing power can be changed by rotating its zoom lens, eye changes its focusing power by changing the shape of its lens, with the help of contraction and relaxation of certain muscles located inside the eyeball. These muscles must be at rest to correctly access the eye's focusing power. This is also the reason why we use cycloplegic or muscle paralyzing drops before estimating the amount of refractive error. Misnomer. Both hyperopia and myopia have abnormal distant vision, i.e., they cannot focus distant objects clearly. But the unique thing about hyperopia is that if these patients increase the power of their lens, by contraction of certain intraocular muscles, they can focus the image accurately on their retina. This will result in excessive and continuous use of intraocular, ciliary muscles in order to keep the image focused on the retina, resulting in pain. Also, when they try to see near objects, their eyes will require even more focusing power, which these muscles can no longer provide, hence causing near objects to become blurry. So, a lot of hyperopic patients, not all, with less degree of hyperopia, will say that they see distant objects clearly, but they have pain or discomfort in their eyes, or their eyes get tired, and also near vision is mostly not that good. Hence, these patients are mistakenly called farsighted. Cause 1. Curvature. Curvature of cornea or lens is flatter than normal. 2. Axial. Short axial length of eye. 3. Index. Decrease in refractive index, i.e., light bending, focusing power of the lens, e.g., in cortical cataract. 4. Positional. Posterior displacement of lens, e.g., after trauma. 5. Aphakia. Absence of lens in eye, therefore, eye cannot focus light rays on retina. Types. 1. Total hyperopia. It is the total refractive error, calculated after complete cycloplegia, intraocular muscle paralysis, induced by certain drops. 2. Latent hyperopia. Amount of hyperopia corrected by the focusing power produced due to normal tone of intraocular ciliary muscles. It is usually 1 diopter. 3. Manifest hyperopia. It is the remaining portion of hyperopia, divided into facultative. Amount of hyperopia corrected by the focusing power produced due to active contraction of ciliary muscles. Absolute. Amount of hyperopia that cannot be corrected even by contraction of ciliary muscles. Clinical features. Symptoms. Eye straining or discomfort. Asthenopia, including eye tiredness, pain, headache, or mild photophobia. Blurred vision with eye straining, when muscle contraction attempts but fails to correct hyperopia. Blurred vision only, when refractive error is high and cannot be corrected at all by muscle contraction efforts. Inward deviation of eye, convergent squint. Normal patients require to move their eyes inwards while focusing near objects. This is enhanced in hypermetropic patients, causing their eye to move inwards intermittently or constantly. Signs: small eyeball, corneal diameter may be small. Retinal exam might show false changes due to distortion of image when hyperopia exceeds 5 diopters. Diagnosis: retinoscopy, a handheld device that throws light in the eye and allowing us to observe its movements and reflection, hence helping to confirm the refractive error. A-scan, a small ultrasound probe that throws ultrasound waves in the eyeball and then detects their reflections or echo timings, calculating the eyeball length. Note: at birth, all eyes are hyperopic, plus 2.5 to plus 3 diopter, i.e., light is focused behind the retina. As the eyeball grows and at about 6 to 7 years age, eyeball is of normal size and light is now focused on the retina, or emmetropic. In some people, it continues to grow, causing myopia, or light is focused in front of retina. Treatment: unlike the camera, maximum 2/3 focusing in an eye is done by transparent front part, cornea, while the rest, 1/3, is done by the lens. So while treating these patients, we have to increase the focusing power of the eye so that the image is formed on the retina instead of behind it. This can be done by using either a converging lens, e.g., non-surgical treatment, glasses, contact lenses, or some surgical procedure. Surgical treatment: making the central part of the cornea more curved. This includes different methods that were changed and advanced depending on reduction of side effects and recovery time and improvement of degree of vision. PRK, photorefractive keratectomy, remove corneal epithelial cells by a solution. Then use laser to reshape cornea, i.e., making it steeper, and then apply a bandaged contact lens. Side effects include pain and recovery is in 1 week at least. It corrects 2 diopter hyperopia. LASIK, laser in situ keratomiliosis, corrects up to 4 diopter, a famous and frequently performed surgery nowadays. In this procedure, a device, keratome, slices a flap of cornea, 160 micrometer. Laser is applied to change the corneal shape, and then the flap is repositioned. Advantages. Advantages over other procedures: absence of post-operative pain, more rapid visual rehabilitation. Conductive keratoplasty. It involves getting radiofrequency energy to corneal stroma, causing change in its shape. Can correct low to moderate hyperopia.